Michael, for this introduction. Ladies and gentlemen, it's a great honor for me to be here at this meeting, a very interesting meeting about IVF and the internet, a topic where I've worked on for the last maybe 10 years. Indeed, I used to be I was a gynecologist at Radboud University Medical Center and head of the IVF team. It's one of the biggest centers in the Netherlands with about 2,000 treatments a year. And we are, with our team, involved in a lot of research on the topic of patient-centeredness and e-health solutions. But first some inspiration. Of course, we already had a lot of inspiration from Jamie, but I want to add 3 sources of inspiration to that. 2 books and 1 pop artist. But let's start with the books. The first one, maybe some of you will know it, is from Clayton Christensen. He's a Harvard professor. And it's a very inspiring book about disruptive innovations. And Clayton Christensen made the distinction between 2 types of innovations. The first type are the sustaining innovations, and the second one, disruptive innovations. And sustaining innovations make things good and better and more, and very often also more expensive. And we are used to that kind of innovations. If we want to improve our practice, we often stick to the sustaining innovations, and things become better a little bit, but they are based on the same paradigm as the other improvements in our healthcare practice were. And disruptive innovations are different. They make things more affordable and more simple, and that's a great distinction between sustaining innovations. And those disruptive innovations, they are not good for the current organizations, as Jamie already told us, but they are good for human mankind, and that's important. They make things more affordable and more simple. Quite inspiring book. The second book is even more inspiring. That's a book of Clay Shirky, and that's a book about, the title is Here Comes Everybody, and if you haven't read it, I can recommend it to you. It's very inspiring about the role of the new world, the 2.0 world, and the impact on our society and on the way we organize things, and especially the way how we do things as a group of people. The normal reflex is that if we want to do something with a group of people, we build a building, we hire people, we pay them, we make some people, we give some people the rights to do the management of the organization. And the new way of doing things with a group is online, is more in networks. It's more about a fluid way of working together without all the classic aspects of an institution. And Clay Shirky is writing in this book about spectacular developments of the internet and especially the social consequences, but it's also pointing at the great impact that the change that will happen. And that's important. The consumers will be the new producers of their own products. So if you translate that to the situation in healthcare, maybe the patients, for a part, will be the producers of their own care. And we had some examples during the last talk of that really big change. And Clay Shirky compares the new developments now with a new democratization wave. Just before around 1500, when during the invention of the way how we can make books, and that changed, of course, the whole society. And he expects that we will have a period of more than 60, 80 years of social chaos and new organizations coming out the next age. So quite interesting, a little bit provocative book, but it's good to read. And the third source of inspiration is Prince. Some of you will know that he changed his name in the artist formerly known as Prince when he decided to make a different kind of music. And sometimes language is a barrier for innovation, because the word care means that we care for our patients, and it says how we did things in the past. And if you want to find words for things that we will do in the future, it's quite difficult. And especially the name patient is also a difficult word, and I wrote a blog, and it's published in the Minerva Medicine, about the word patient, and patient is more, it came from the Latin word patientia, and that means patient, be patient and wait and see what happens and suffer, and it's more or less the old role of a patient in our practice. And then just for a joke, I wrote a blog and a paper and called it the inevitable, formerly known as patient, because I was looking for a new word, and citizen or human being or was not quite what I was looking for. Just as and maybe TIFKAP is a better word. I do not know. How did I get involved in this world? I was, as I said, I was a gynecologist from 1996 on, and I chaired the reproductive medicine department of University Hospital. And in the Netherlands, one out of six couples has a fertility problem. And in the Netherlands, we perform about 16,000 IVF treatments. And on this moment, 1 in the 38 children is the result of an IVF treatment. I think that Denmark and Israel, maybe this number is even higher, but the Netherlands, it's quite high. And this is not with this is only IVF, so IUI or ovulation induction is not included in this number. And of course, yeah, you all know that IVF is they are young people. They are used to the internet. They are emotionally involved in their process and their disease. So maybe it's a good population to look at all the possibilities that internet can offer to medicine, to healthcare. And I just started, I started in 2001 with a meeting of patients in this little castle, the Heina Castle near our university. And I asked patients in the region of the Netherlands, it's the eastern part of the Netherlands, and I did some focus groups and asked them, what do you think about the care that we as professionals provide to you as infertile couples? And it was, that evening caused a real paradigm shift for me, because it was very impressive what I heard during that meeting. And two things were important. The first thing, do not look at this matrix, it's only a way of presenting the data, but I was impressed by the way, by what patients were telling me. They say, okay, doctors need social skills, we need more attention, the lines should be shorter, there's no clear goal of the whole complete network of care in our region. You should collaborate better. A lot of work is done twice. We need more compassion and that kind of things. That was one. But two, I was very impressed by the power that was present in the group in the Nijmegen Heina Castle, and that's a power of patients that we do not use as doctors. As doctors, we think, okay, patient, be a number, do not ask too much questions because that costs a lot of time. And actually, we are saying to the patients, do not be a human being, because that hampers the process that we are doing. And we do not use that power. And there was a plea for let us help, let us patients help in your process. Maybe the process can be better, and maybe the outcome can become better as well. And it was a call for patient-centeredness. And that caused, as I already told you, it caused a paradigm shift, and together with some members of my team, I started dreaming about how can we improve the care, how can we change to a more patient-centered care, and what are the barriers and the facilitators to reach that dream. And patient-centeredness is not well known, but actually patient-centeredness is one of the 6 dimensions of quality of care as defined by the Institute of Medicine. And of course we all know the 2 dimensions, safety and effectiveness. Actually, from a doctor's perspective, that are maybe the most important dimensions of quality of care. In our field, it's how big is your IVF success rate. And safety, of course, we think of multiple pregnancies, and we think about ovarian hyperstimulation. Some of us are interested in efficiency, but patient-centeredness is one of the neglected outcomes, neglected dimensions of quality of care. And It's a little bit a vague concept. It's about the values and the needs of patients. And I think the definition made by the Institute of Medicine on this slide is the best description of the concept. There's also a huge gap between evidence-based medicine and patient-centered medicine, because evidence-based medicine is more about numbers. It's about you see a patient as the average of a group. Of course, it's necessary, but the gap now is too great, and one of the problems with patient-centered medicine is that the concept is vague. There are a little amount of tools to study patient-centeredness, to measure the dimensions of patient-centeredness. So we have to bridge the gap between those two concepts of medicine that are both very important. In Nijmegen, we did it with a lot of studies, a lot of PhD projects. We started with stress and IVF from Chris van Raak, now the chairperson of the Special Interest Group's Psychology of the European Society for Reproduction and Embryology, ASHRAE, and Jesper Smeenk, and they studied the psychological aspects of IVF. And now Angelique van Dongen, one of our gynecologists, is now studying an online cognitive behavioral therapy for the prevention of stress and anxiety. We made a measurement to screen IVF patients before the treatment to assess the chance that they will have problems about stress and anxiety. And now we have made a module, a self-help module to help them to prevent stress and anxiety by themselves. I look forward to the results of that study. The third one is from Arno van Peperstraten. It's about shared decision making in the choice one or two embryos during the transfer, set or dead. And it was a beautiful, he ended his PhD project with a beautiful publication in the BMJ about a randomized controlled trial about shared decision making in set and dead. And the surprising result of that study was that patients were, if we randomized the group, one group of patients, the doctor decided, and the other group of patients, the patient decided themselves about the number of embryos. And the surprising result was that patients more often choose for one embryo if they had a good decision tool and were supported in decision making. So do not underestimate our patients. They make better and more cost-effective decisions than we would expect. Another example is from Selma Mourad, who did a huge study about the guideline implementation. In the Netherlands, we have a lot of guidelines around reproductive medicine, clinical guidelines, clinical practice guidelines. And we know that if we make clinical guidelines, the adherence to the recommendations is not that high that as high as we would want. And so the implementation of guidelines is a very important topic. And Selma studied the power of patients to increase the implementation of the recommendations of guidelines by telling the patients what are the main recommendations of the guideline, how can you convince your doctor to stick to the guideline. And we empower them and did a cluster randomized controlled trial about that topic. Elvira den Breje, she's almost finishing her PhD project now. She did a study about guideline development and the role of patients, because many times we as professionals make the guidelines, and they are about to care for patients, and patients are not involved, or they are involved, but the effect of their involvement is not very high. And we look for better methods, new methods, innovative methods to use the power of patients in guideline development by using wikis. And it's quite interesting to see what happened. A lot of patients visited the wiki website and made recommendations about our own care. And interesting was that we decided as the whole professional organization in the Netherlands that we promised to include the top 10 recommendations of patients. They are not level 1 or level 2 as the evidence-based medicine people tell us, but we call it level P, the level of patients. So there now are national guidelines, have a lot of patient-made recommendations, and they are made by a wiki on the website. Tom van der Belt is also studying the role of wikis but now in patient education. If we make information leaflets for patients, they are often written by nurses or by doctors, but they are about patients. And now we ask our patient to improve the information leaflets that we have made for them. And we put the patient the document online and ask the patient, okay, go your way and improve the content of the information leaflet. And they make their own information leaflet. So they are producer of their own information provision. I already told you about the vague concept of patient-centeredness. So Inge van Empel made try to measure patient-centeredness and made a questionnaire about patient-centeredness. We call it the PCQ. We validated the tool, and we tested it in about 1/3 of all Dutch IVF centers, and benchmarked those centers and gave the feedback to the centers, and it's quite interesting to see what is the result, because it's not only that you can get that you will receive one complete overall score of the level of patient-centeredness, but of course patient-centeredness has a lot of dimensions, and you can also see on what aspect you could improve your center. Elodie Dansef from the University of Leuven is one of my PhD students. I guide her together with Thomas de Hooge from Leuven. And she did a lot of focus groups in 6 European cities and made one European measurement of a patient-centeredness questionnaire for all European countries. And she is now testing it in 5 European countries. And Dana Huppelschoten did a project, is now working actually on I think a beautiful randomized controlled trial. We measured the level of patient-centeredness of 32 Dutch fertility centers. And then we asked patients for the intervention group to participate in the intervention. And we asked them, can you help us? Can you help us to improve the quality, the level of patient-centeredness of that clinic? By, for instance, give them feedback, help them with the improvement projects, and the control group will receive only feedback, classic feedback. I look forward to that result, because I think that's a very important study, because patients are helping doctors to do their work in a better way. Wouter Tuil did his PhD study on the virtual IVF clinic. I will talk about that project later on. And Annemijn Aerts, present in this room as well, will have her presentation tomorrow afternoon about health communities and the barriers and facilitators for health communities. Now, some remarks about the virtual IVF clinic that we started in 2003, and actually that was one of the first IVF communities related to an IVF center. It was a website that contains about 3 parts. It was about one part was general information, interviews, education leaflets, a day planner, and that kind of things. The second part was that patients had online access to their personal health record. We gave them all the data that we have in our clinic. Probably we were one of the first centers, maybe also outside IVF, that did that during that time. I thought banks are doing that, why hospitals not? So all patients for more than 9 years can see their own test results, pictures of embryos, results of semen analysis, hormone levels, letters that we write to the GPs, etc. And the third part of the website was a communication part, and especially a chat part and a forum part, a bulletin board. And they can ask questions to the nurses or the doctors of the team, and we ensure them that they will get an answer within 1 day, 1 working day. And that is very important, a very much used aspect of the website. But I will go on that. I will elaborate about that topic tomorrow more. Here you see one screenshot of the old website. And this is part of the personal health record. All patients can see the embryos that we will transfer that day. So a lot of patients already have seen the embryos that we will transfer later on that day. So they log in at home, see the embryos, see the quality of the embryos, and are informed about the process that we are doing, and they are more involved in the complete process, and that has a lot of interesting results. It's now online for more than 9 years already. On this moment, more than 5,000 people are online, more than 100,000 forum items. So not only hits, but there are original questions. And interesting to see is that patients are the motor of the innovation. In 2003, in 2 months, almost 90% of all patients were member of this community. And it's a shame to say, but at this moment, about 50% of the gynecologists of our team have never been online in this community. So I think they missed the new world, and from the beginning on, more than 90% of the patients are online. So interesting to see that the innovation is not promoted by physicians or nurses, but by patients. It leads to more trust, less complaints. I think that trust is a very important word. And to implement this kind of innovations, we have to trust our patients, and the patients thank us by that, by giving us trust and in the way in our work. Less consultations because there are less questions. Some marketing benefits, and we have won several national prizes. And Wouter Tuil wrote his PhD thesis about this topic. That about the virtual IVF side, but now we are going to the next step. And I heard Jamie already talking about communities and the role of communities. I think there is a great future for health communities. And the problem is that we have organized healthcare at this moment from the perspective of the provider and the institution of the provider, the hospital or the practice or the IVF center. And but actually, we should organize healthcare from the perspective of the patient. And as we know, the patient is not only limited. The path of the patient is not limited to our own organization. The patient also go to a psychologist, a GP, a urologist, to a physiotherapist, maybe other medical specialists. So actually, the path of the patient is a network, and it's an individual network. There's no chain or a path that 100 or 1,000 patients are walking. No, every patient has his own healthcare network. And that's the point that we have to make the next years. We should organize healthcare more from the network of the patient. Now, it's difficult to pronunciate Michael in English, but it's Mijn Zorgnet. And MyCareNet, we developed MyCareNet, and that's a provider of health communities, not only limited to IVF, but you can use it for IVF. And actually it's a social network. You can say the Facebook of the Dutch healthcare at this moment. It's now online for more than 2 years. And it's safe because we used the national identification and authentication method that's available for all Dutch citizens. And we use a card that identifies doctors, and that's also a national available card for all healthcare providers. So it's safe, you know who is online, and you can do business as a patient with a doctor, and you know that he or she is really a doctor because he used the identification and authentication method that I described. And what we want to do in MyCareNet is to connect patients and professionals, and especially around the primary process when there is when patients are active with their own health. two main products we have. The first one are private health communities. You can see the virtual IVF clinic that I showed you as a form of a private health community. It's only for members, so members only. So if a patient wants to be a member of our community, she should be a member she should be one of our patients of our IVF team. And there's a secretary who will check that and will give her access to the community. And private health communities are communities of a professional team with their patients, and it gives a lot of new possibilities to interact with your patients. You can blog, you can answer questions, you can put your information leaflets in a wiki. You can store the main files of your team. It's possible for all members to chat. You can organize chat hours with doctors and that kind of things. And it's not only limited to IVF. It's more or less a platform. So every clinic, even for instance, breast cancer, or a team in Amsterdam for prostate cancer, a few clicks and you have your own community. And that's interesting to see that the technique is not a problem anymore. It's the social, cultural change of innovation that is the main challenge for the period thereafter. It takes only six clicks to have your community, but it can cost maybe 6 months to have all the people in your team aligned, that they can answer the questions of people, not only live in a one-to-one setting, but also in an end-to-end setting in a community. And nurses and doctors have to learn that, because it demands different skills. So that are the private health communities. And the second product is maybe more interesting. It's the personal health community, and it's of course, we know that the health records are in the hospital or are in the IVF clinic, and health records are meant for making our work more easier. It's made for the work for doctors and biologists, embryologists, and nurses. And now there's a move towards personal health records, that the information is together with the patient. And of course, we know, for instance, Microsoft Health Vault is a form of a personal health community. And we make a step further. We made a personal health community. So not only personal health record, but also the communication about the information of the patient. The information should not be in the hospital. The information of a patient, the health record, should be with it by the patient. And the patient should decide with whom the patient want to share that information. And I can give you a few examples, I think. Here you see a screenshot of the new virtual IVF clinic of our center, but there are now more than, in the Netherlands, are more than 400 or 500 communities already within 1 year. And it's quite active on a daily basis, maybe in one community of 500 people. I think every hour there's a message or a question or an answer or a blog or that kind of things. It's quite active. And it's in Dutch, unfortunately, but we call it the Dutch Digital Fertility Outpatient Department. It's here you can see your own personal health record. There is general information. There's activity. The possibility of blogs, and that is a new way of giving information to your patients. Question and answers can be put in a forum. This is for files, the wiki, the chat, and that's the membership part. And you can send message to other people in the community and that kind of things. A very easy way, new way of communicating with your patients. And sometimes it's quite interesting if patients ask a question. We answer within 24 hours, I already told you that. But sometimes you see that patients are quicker than we as professionals, and they answer the question. And if you take a look, very often the answers of patients are better than the answers of nurses or doctors, because they are micro-experts of their own disease. And of course, in one section, questions to the team, we always check the answers. But I think maybe 1 in 100 we have to correct, because the answers of patients are often very, very good. Don't underestimate your patients. I often say that. Here you see this is my hospital. It's my personal health community. I'm the boss of this personal health community. And it's my safe and secure place on the internet, in the cloud, where I put my medical information, and members of my team can put their medical information in that cloud, in that safe place. I can have my own diary about my disease. I can have discussions with members of my team, and there are only a few members of the team. This is a friend who's member of the team. This is myself. This is a little bit of a joke, but that's my gynecologist. That's my other role, of course. And this is my daughter. It's just only the beginning. But my GP is now a member of my personal health community. My wife is a member of this personal health community. I trust them, and I say, okay, you go for my health, and I will allow you to be member of my personal health community. And there is a link to, we are working now to make a link here to Microsoft Health Vault. It's possible to store pictures, letters, all kind of files in this vault, etc. It's quite interesting, and it's a new development. It's now only 6 months online, but we are now doing a pilot with more than 100 Parkinson's disease patients. The oldest patient now with a personal health community is 81 years old. And he is very positive about his own personal health community. So I think that in the future, the patient will be the central unit of organization in healthcare. Everything will be arranged around the individual patient. And one interesting, I didn't tell you that, but there you see a tab apps. And we are now working on several apps that are little programs, little applications from a library. We have a library, and you can click on an app in a library. You can put it in your own personal health community, and you can fill it in. And this is a decision of a guideline-based decision support instrument. And it's in Dutch, unfortunately, but you have to answer some questions about your history and the semen analysis and the duration of fertility. And then the prognostic model of UNO will say, what is the chance to get pregnant this coming year? And is it necessary to go to a gynecologist, or can you wait and stick at the office of the GP? And I think that in that personal health community and the personal health records, the role of small applications made by third parties that are put by the patients in their own community will be maybe the future of the personal health records. And so I do not believe in national connection points between hospitals to exchange data of patients. I believe in individual connection points at the level of the patient. So the times, they are changing. It's a new age, and the new doctor will change, and with new roles for doctors and patients. The doctor will move from God to guide. At the time of the paternalistic doctor who knows what is good or is bad for the patient, that time is gone. Don Berwick, I love that guy. Michael, you probably know him. He was the guy from Medicaid and Medicare revolution, I believe. But he made a very beautiful statement about the new doctor, and he said, okay, we have to change from host to our patients to guests in their life. And that's an important paradigm shift because when a patient has a problem, he normally goes to the hospital of the patient, and the doctor said, okay, welcome patient to my environment. And in the future, that will be different. The patient has a problem and said to the doctor, okay, doctor, I invite you to my personal health community. Be welcome in my world and behave as a guest and help me to improve my health care. The new patient will change from a passive object that is cured by us doctors to an active subject that plays a role in that process. As I already told, the patient will change from patient to person, maybe TIFKAP. The new healthcare organization will focus on to get things do more in a more simple and more affordable way. And I think that it will change from a physical center, a physical IVF center, to a virtual community or virtual network around a group of patients. In conclusions, the modern patients are changing from passive objects to active subjects, and helped by the new possibilities of Web 2.0, they will grow into the role of co-producers of their own care. And I think we, and this conference is a proof that we should anticipate on these developments and invest in web tools that can really help these persons. And I will end with this last slide, and I thank you very much.